having worked 35 years at the Jewish, and before that at Summit School as a psychologist, and before that at Jewish Vocational Services, the Sheltered Workshop with adolescents. My very long history, but I'm only 25, but I work 24 hours a day. My long history tells me that when you help the family, you help all the individuals in the family. And when you help the individual, they go back into their family milieu, and some of the work that we do in individual gets undone. So when you help to change the family and work with every member of the family, everybody benefits. So I'd like to talk a lot about that. So we can start with the prevalence, and I'm sure every talk you've ever had, you've heard the same statistic. During their lifetime, 1 in 5 Canadians will experience mental illness. Approximately 2/3 of mental illness begins between the ages of 15 and 25 years of age, first episode psychosis. That's not to say that we don't have children in child psychiatry, where I work, who have the prodrome, or the beginnings of serious mental illnesses, but they're not as obvious, and so we work with the children and the families at that point to try to prevent what can happen in later adolescence and in the early adulthood. So the age range, 15 to 25, covers a few critical developmental transitions, and those are the points in time when it's difficult to make the transition for individuals who will then have mental illness. The transition from childhood to adolescence. The point there is that when children are very young, our job as parents is to raise them to become increasingly independent. What did the doctor say when you were giving birth? The doctor said, push. Push, right? The safest environment of all is in the uterus, right? That's where the baby's the safest. It's not out in the elements. It's protected by the mother's womb. It gets fed, it gets nurtured, it moves around. It has a very, very sheltered life. But after 9 months, the doctor says, push. Because if the baby remained in the sheltered environment forever, it wouldn't make it past the next month. So the protection would be toxic for the baby, right? And if you take that into living human beings, overprotection can become toxic because the child never grows up. So we have to help parents understand that the 2-year-old is allowed to wander off farther than, sometimes even maybe farther than you can see for a moment. And the 2-year-old comes back to make sure that you're still there. And the parent watches the 2-year-old move away. But there are some parents who will carry their 2-year-old around. And so in a way, it's wonderful, it's loving, it's caring, it's nurturing. It's all those things that we're supposed to do, but it's too much. We must let our children grow, take chances, move away, explore, and find their own self. But those are critical periods, those transitions. So some children can't make it. They can't become independent. Those are the ages at which mental illness sometimes disables them from crossing into the next stage. And the same from adolescence to young adulthood, and that's the very fragile period when first episode psychosis can manifest itself and other psychiatric illnesses. But there are usually, and you probably know better than I, signs all along the way which which you may only recognize sometimes retrospectively, of difficulties along the way. So there's the onset of mental illnesses like the psychoses and schizophrenia, depressive disorders like bipolar disorder, anxiety disorders, which are very common and very prevalent, like obsessive-compulsive disorders, panic disorders, etc. Personality disorders as well. Personality disorders aren't really mental illnesses, they're personality illnesses. They don't respond really to medication, but they're very difficult. As much really for the patient as for members of their family. Substance abuse, and that's something that parents are terrified of, that their children in high school will start doing drugs and become dependent on drugs, and which will obviously at certain points in their, because of their age, their brain is more susceptible to damage from the drugs. But then during these periods of transition, substance abuse can take over, eating disorders become very prominent, sexual orientation conflicts, and so on. We can say that it's difficult for anyone to deal with strange thinking, strange thoughts, strange emotions, and sometimes bizarre and unpredictable behavior. And I'm sure that when a child in the family first begins to manifest unusual behaviors and even psychosis, it's very frightening for parents. It's bewildering and it's exhausting. So parents become alarmed and experience shock, fear, sadness, anger, confusion. These are all feelings and thoughts that families where there is no mental illness don't really have, or physical illness, don't really have to deal with. And so you begin to have to deal with yourself as well as your child, as well as the other children, as well as your spouse, as well as your parents, the grandparents. And even when the child is stabilized on medication, sometimes the negative symptoms, because the positive symptoms are the florid psychotic symptoms, but the negative symptoms, like the apathy, the lack of motivation, the withdrawal, the lack of caring for oneself, they're just as difficult and frustrating and sad to have to deal with as well. All parents have hopes and dreams for their children as the children pass through the various developmental stages toward autonomous adulthood. So when one of their children becomes mentally ill, this immediately impacts the hopes and dreams of parents. I have to say that it's not so dissimilar from parents who learn that their child, young or older, has a physical illness or a medical illness, diabetes, cancer, the same kind of reaction for a parent, the same kind of emotional jolt, a shock to the system. When the acute episode is over and symptoms abate right at the beginning, everyone feels relief, hoping that it's a single episode. And it does happen that there's a single episode and then nothing. When the mental illness is a new phenomenon and the child is now doing better, some parents believe that the symptomatic behavior will never return. They try to find answers. Family members may have trouble understanding the difficulties that the child, him or herself, is having. We talk about the children who have mental illness as if they are not feeling themselves what's going on with them. And sometimes we don't understand what they're feeling. Families and parents hope that the child will snap out of it, given the right support and encouragement. Some members of the family believe that the symptoms are caused by some other physical problem or external stressors like the peer group in adolescence, or stress due to academic failure. Some members of the family do understand the reality of the illness, and some do not. And that itself becomes a problem in the family. Those who do not understand the reality of the illness may blame and denigrate their child, their ill child, for the unacceptable behavior. Our first reaction is to try to get the child functioning well. So we think that the child is doing it on purpose, or that the child is just being obstinate, oppositional, defiant, and so the parent kind of deals with the child in that mindset. So they could denigrate their child because of the unacceptable behavior, because of their withdrawal, lack of motivation and achievement. They may attribute the ill child's behavior to being lazy, stubborn, oppositional, defiant. Those who do accept the reality of the illness feel then in the family that they have to protect the child from the parent who doesn't accept that it's a mental illness. So you see that the parents they're at opposite ends, and one feels they have to protect the child from the other parent. Relationships within the family are affected, and this to me is one of the most important points. Families may become angry, frustrated, and overwhelmed as they struggle to get back to a routine that they had previously taken for granted. How much easier it is to believe that everything will go on as before, rather than focus on the changes and the adjustments the mentally ill child and the family must make. Always hoping to get back to what was, rather than saying, we all have to change to accommodate the reality. But it takes families a long time, and those are the dynamics of the family that are very difficult for everybody in the family. It's normal for the family dynamic to change when one's child is diagnosed with any serious illness, physical or mental. It takes time for each member of the nuclear family to accept those changes in their child. Imagine brothers and sisters seeing their sibling having such difficulties and kind of withdrawing from life, kind of not functioning. And it takes time for the family to establish a new reality, a new relationship with the child who's suffering from mental illness, and a new routine. And the routine definitely changes. Remaining in denial often results in the family going crisis to crisis because they're not getting the help that the child needs. You know that mental illnesses come and go, or the symptoms come and go. Sometimes it's better, sometimes it's much worse. Families have to live from crisis to crisis, and they become more frustrated, more bewildered, because both the ill child and the family have no control over what's happening and no understanding for what's needed. The needs of the child who is ill become paramount. So all the focus is on what this child needs. Such constant stress and concern can create serious family problems. Family life can be unsettled and unpredictable because it goes according to the symptoms of the illness. It becomes very difficult, almost impossible, to plan to do things together as a family because of the symptoms. At the same time, there remain the needs of the other family members and the usual problems of everyday life. Everyday life is not simple. Families struggle who don't have a mentally ill child, or children who don't have a mentally ill parent. When the mentally ill child takes a lot of space, which we all understand, then the other children don't have as much space. And so many things start happening with them, right? For example, the healthy children who need the attention don't get the attention. They can start seeking attention elsewhere. They may be prevented from inviting friends to come over to play because of the difficulties of their sibling, because of the symptoms. The so-called healthy children in the family become parentified because they want to help the parent. So they take on more responsibilities than they should at their age, and they become overburdened themselves. So the parents are overburdened. Sometimes they don't agree with one another on how to deal with the situation. The children become overburdened, and their needs aren't met. So this is what happens in the family dynamics. In many cases, parents disagree on what should be done, or find that caring for the ill child leaves them too exhausted to give much attention to the partner. The relationship between the spouses can sometimes become vulnerable enough or fragile enough that divorce ensues, which puts additional pressure on single parents and additional pressures on the children. The whole thing's a very draining experience, and can create an atmosphere of confusion and resentment, and can result in irreparable damage to the couple and the relationship and to the family as a whole, as I'm saying. Families become worn out, discouraged dealing with the child who has mental illness. They may feel unable to cope with living with an ill person who has to be constantly cared for. Members of the family feel trapped and exhausted. It's hard to talk about that to anybody. Imagine saying to somebody, maybe a family member, maybe a therapist, I'm exhausted and I can't anymore. Some families, because of the nature of the illness, may feel completely out of control, with no control over their child if they're not getting the proper treatment, if they don't know enough about the mental illness. Families become overwhelmed because the child with the mental illness has no limit set on their behavior. Their judgment is off. Their emotions are off, depending on the diagnosis. So their acting out is not governed by self-control. Their executive functions are not working, and so the parent has to react to that. The parents have to, and the family has to react to it. Sometimes the person who is ill can rule the family as a tyrant, and they can be demanding, they can be threatening, they can be aggressive, they can have all kinds of unacceptable behavior. During the acute phase of the illness, they don't understand their effect and the effect of their destructive behavior on people around them. Families may say they can no longer stand the abusive behavior, the threats. I've heard parents tell me that they sleep with a knife under their pillow because they're afraid of their own child. Parents don't know how to handle the children when they're out of control. Prior to the child developing or manifesting a mental illness, most families have little knowledge about mental illness. You have your ideas, your concepts of what mental illness is, but you don't really know what it is intimately. Many families have unrealistic or incorrect or false information about mental illness. Many don't know to whom to turn for realistic information. So when it happens, who do you talk to? Who do you? Today we have the internet, but that can be as dangerous as it can be helpful. And it's not really a source of information that can bring the correct nuances to your very situation. Without accurate information to help the family learn to cope with their child's mental illness, various members of the family can themselves become hopeless, become depressed, become very pessimistic. So the family members themselves begin to develop mental illness, depression, anxiety. Like any other parent, you need to know what's going on, what it means, what can help it, and its prognosis. Will it get better? Won't it get better? Is it chronic? Is it just acute? They need to know how the illness affects their child and will affect their child over the child's lifespan. They need to know how the symptoms can best be managed. And that's when the family starts feeling more empowered. The empowerment may bring with it sadness, depression, feelings of disempowerment, but at least they can start to begin to work. The first step for the family is to find sources of information that can help them. So that brings us to mental health professionals. Now, when you look in the literature, what you hear over and over again, and this is just sort of a little preface to what I'm going to say, what you hear over and over again is that when they have to do with mental health professionals, the professionals don't listen to them. The professionals aren't always open to hearing that really the first line of treatment is the family. The first line of treatment is the family. So when the professionals become involved, they make decisions without sharing it. They have very short answers to very deep questions. Families of the mentally ill frequently feel as though they are second-class citizens in the process, and maybe not so much in the present, I hope. But in the past, the family was blamed for causing the illness. We used to have theories when I was in school, which a really long time ago, of the schizophrenic mother, the refrigerator mother. Thank goodness we don't think in those terms anymore. But imagine having to cope with a loved one who's suffering from a mental illness and being thought to be the cause of it. But that's what we had. And maybe that today there are professionals who still kind of follow that line of reasoning, or have a sense that the parents are somehow responsible. You're not responsible. You're not responsible for that. However, mental health professionals are important because they can provide you with thorough information about the illness, about its symptoms, about the prospects for recovery. What does a family want to know more than anything? The prospects for recovery. And suggestions on how to help to manage the symptomatic behavior. With some of the mental illnesses, like schizophrenia and bipolar disorder, and some others, these are chronic illnesses. So it's very important to learn how to manage the behavior. To give you information about medications, and you know medications are changing constantly. And you hear many families, we do even in child psychiatry, hear many families saying, oh my God, my child is a zombie on that medication. But there are other medications. Families feel that medication is not good to give to their children. But it's one of our main treatment modalities. Side effects of the medication and how medication interacts with other medications. Healthcare professionals also should provide families of adult children with mental illness with written materials, with references, sharing expertise in problem solving, and communication resources. Because as the children get older, the same developmental stages have to be considered. So when a child of 25, let's say, has a mental illness, keeping them at home may not be the right thing for them, because at 25 and 27 and 29 and 30 and 40, they need to have friends, like every 25 and 27 and 29-year-old needs to have. They need to be living independently as they can, and that needs to be assessed in assisted living, in independent living, with some assistance, and parents need to be counseled on that. Keeping a child home forever may not be good for their own social and mental health. Everybody needs to grow up and become as autonomous as they can. It comes with a lot of fear for the families, it comes with a lot of reluctance, comes with a lot of hesitation. How will they manage? A lot of overprotection, but remember what I said. If you overprotect too much, it's toxic. So it's healthy to let go, even if it feels wrong. Trust me, it's right for the person, because we're not going to be around forever. And the only way for anybody to learn how to manage on their own is to practice. So if you don't give someone a chance to practice functioning on their own, they're not going to be able to when the time comes and they have to. So that's part of the education process that therapists, mental health professionals have to help families understand. Today, I think fewer and fewer and fewer people in general are not knowledgeable about mental illness. There is still the stigma. And it's still hard to talk to people about the fact that you have a child with mental illness. Think about it, when someone has a chronic physical illness, everybody helps. You hear about a diagnosis of cancer, everyone's at the door with meals, talking, doing whatever they can. Family has a child who suddenly has a mental illness. Does anybody come running with a meal? Does anybody say, you know what, go out for the day, let me help you? No. It's incredible, but that's a fact. And so stigma, even though we think that it doesn't exist today, it does exist today. More changes in family dynamics. Family members can become reluctant to invite anyone to the house. And I remember having doing an assessment with a family, and actually it was when a parent had suffered from alcoholism, which is just as much a mental illness. And the daughter, who I was interviewing, said to me, I would never invite a friend over. And imagine growing up and not being able to invite friends over. I would never invite a friend over because I never know what state my mother's going to be in. And if I open the fridge, there are lots of bottles of Sprite. It's not really Sprite. It's gin. And the healthy people in families are deprived of a normal life that anybody else can have. And sometimes the patient themselves can't handle. Let's say you want to have Christmas dinner at home and you have a mentally ill child who would become overstimulated and perhaps inappropriate and perhaps aggressive or at least unpredictable. Also, family members may become anxious about leaving the ill person at home, so you can't go out, can't go to a movie, you can't go on vacation, you can't visit a friend because you're afraid, you're worried. What could happen when you're not home? And you can't leave a babysitter because what babysitter is going to stay with your 24-year-old schizophrenic son or daughter? So you see the restrictions on the family and how the dynamic then changes, because with these restrictions, tensions continue in the family, between the spouses, between the children and the spouses. If there's a member of the family that has an illness, to me, the whole family has the illness. The family is the unit, because everybody has it in a different way. So some families become terribly socially isolated and emotionally isolated, emotionally withdrawn, and this creates, of course, feelings of depression, feelings of low self-esteem, feelings of low self-worth. I just want to say that one of the important psychological processes that families need to deal with, and because it's helpful in the long run, is to grieve for what might have been. Is to grieve for what might have been. Like I said at the beginning, we all have hopes for our children. We all have dreams for our children. When a child becomes symptomatic and has a mental illness, those dreams and hopes, we cling to them, but over time, with the chronicity of the illness, we have to give up those hopes and dreams. When we have to give something up, we have to grieve it, we have to mourn it. We have to work it through our system, because we can't move forward if we don't. We can't move forward into a healthier mode, which is to work on managing the health care of our child as they get older, and accepting what is and not what could have been or might have been, or why did it happen. Just wanted to say to everybody who has suffered that it's not abnormal to feel all the emotions, the shame, the hurt, the embarrassment, the anger at the person who is ill, feelings of guilt, self-blame, blaming others, blaming the spouse, and grief. And it's really a mourning process that we forget that that's part of working through the feelings of the disappointment, the sadness of having a child who has mental illness. I'd like to talk a little bit about accessing services for young people. Now, I don't know how many of you have had difficulties in accessing services. I think everybody. We in the profession have difficulty accessing services, and it's getting worse. It's getting much worse. So we now have a totally new regime, and it's called SUS. And don't ask me what it stands for, because I'm not there yet. But apparently they're putting together lots of institutions under one management. In the olden days in child psychiatry at the hospital, we have a department of child psychiatry with outpatient services and day hospital and after-school program for children. And the adult services has, of course, the ward, and then it has a lot of clinics, including crisis, including clinic for personality disorders, and all kinds of clinics, and the outpatient department. And it used to be that you could make the referral directly to the Jewish General. And so the school boards would refer to us, and and private people would refer to us, and we had waiting lists like everybody else. Well, that changed a few years ago, right? So now, no hospital can accept a direct referral, and it has to go, everyone has to first go to their local community center, CLSC, because they want everybody to have access to services in their community, which is not a bad plan if the CLSCs could handle it, and if they had sufficient professionals and manpower to deal with it and sufficiently trained to deal with it. And so what happens from the C3S or the CLSC is those cases that they cannot handle because they're dual diagnosis or many diagnoses, or difficult or complex and complicated cases. They're the ones that they refer to the hospital. So you have to kind of insist that it's a very, very serious case and it has to go to the hospital. And so that's where we now are getting all our referrals from. So there's the hospital, so we call the CLSC's first line intervention. Second line is the hospital outpatient departments. And the third line, or the most severe cases, are the day treatment hospitals and the inpatient services and the specialty services. So whichever hospital has clinics, like anxiety disorder clinics, eating disorder clinics, clinics for schizophrenic patients, those are considered third line, and they're the specialty programs. So the little known secret, but it's becoming really much better known, well, for children anyways, but I think probably for adults too, is if you present at the emergency with psychiatric problems of the nature that you're a risk to yourself or others, so suicide ideation or suicide attempts or suicidal thoughts, you will be referred to a hospital outpatient department immediately, and we have to see those patients within 2 weeks. So you jump the waiting list and you jump the CLSC. Now there are other agencies which offer support and help and therapy for the less complicated cases, and there's social service agencies like OMETS, but there are many others on the West Island that I may not be aware of. Crisis centers like TRACOM, drug rehabilitation centers, and I think you have to be referred, except crisis centers, which you call yourself, but you have to be referred to all these others by a professional, either a physician or because they're specialty drug rehab centers. And I added Pinel because that's for the criminally insane. And they also have an adolescent department for adolescents. And they will take young offenders who have not been helped by other means. So let's talk about treatment. Treatment for mental illness often includes a few different approaches. So there's therapy, medication, and self-care. Support groups like this one, like others, like sometimes this is the only place where you can talk about how you really feel because other people understand because they've been through the same thing. Some people may also find extra supports like income and housing, which the government provides even for children who have certain disabilities and illnesses. The family gets support, extra support, and not housing. There are real limits to the effectiveness of any treatment. I think that's a really important statement. There are so many people who believe that if you tell someone to go for therapy, that they're going to be helped. And I say that because in child psychiatry, we often work with youth protection, obviously. I also, in my private practice, do psycholegal or custody assessments. And I go to court to testify about who should have custody and who shouldn't, and I give my recommendations. And so many times the judges say, therapy for these people. And time and again, I'm having to explain that you can't order someone to have therapy because it's useless. No therapist has a magic wand, so when you come in for therapy, whether you want to be there or not, and you're going to get helped. And the person who doesn't want to be there will definitely not get helped. And it's a partnership between the patient and the therapist. And we work together on moving you along to some kind of improvement or recovery. So, there are limits to the treatment. There are limits to medication treatment. There are limits to therapy treatment, which means that not everybody is going to get helped. Many people are going to continue to need medication for the rest of their lives, and it's interesting. I'm not trying to minimize anything, but in child psychiatry, we're often diagnosing attention deficit hyperactivity disorder, ADHD. And we tell parents that what really helps is a psychostimulant, right? Is Concerta or Ritalin or any one of those medications. And the first reaction often is, medication for my child? The second reaction is, well, how long do they have to take it? And when we say that if a person has impulse control problems and has attention deficit and can't focus and has a real hard time at school, chances are they're going to have the same problems when they grow up and go to work and have families. And they're going to be impulsive, and they're not going to be able to hold their job, and they're not going to finish. They're going to go from one project to another and never finish. They're going to have the same symptoms. So doesn't it make sense that they would have to take this medication forever? I'm sure that the doctors who diagnose diabetes don't have to explain why the child, when they grow up, has to take their medication, their insulin, forever, because it makes sense, it's going to keep them alive. So why would we question in mental illness that a person has to take medication forever? So you know that there's all kinds of therapies. Every year there's any kind of therapy. So now cognitive behavior therapy is like a big thing, and that's mainly for people suffering with anxiety at the base of whatever mental illness they have. And that's often, but not always, an individual kind of one-on-one with a therapist. There's dialectical behavior therapy with DBT, not CBT, and that's Marsha Linehan, who herself was a borderline personality disorder and hospitalized for that. And she's developed this very elaborate kind of therapy, which not everyone is an expert in, but I know that at the Douglas they have a clinic for this kind of therapy. And then there's individual interpersonal psychotherapy, which is basically talking about your problems. And then there's family therapy. And as I said right at the beginning, I'm a major proponent of family therapy, because when you help the media, you help the patient, and you also help everybody else. And family therapy, there are many different types of family therapy. The systems approach is to me makes the most sense, and helps, to get people to talk in a non-judgmental environment, and to talk about their feelings when they begin to trust the system enough, the therapy system enough. It gets people to, it reorganizes family relationships, and it does a lot of things. It's very hard to go into it right now. Another form of family therapy, which I was doing for about 25 years at the Jewish, with families in child psychiatry, but at one point I actually had a family referred to that group, to one of my groups, with an adult child living in a family with both parents. And that was multiple family therapy. So I would see 5 families together in one room. And multiple family therapy actually started in the United States on a ward, on a psychiatry ward where there were schizophrenic patients. And the doctors found that every family that came in to see their patient, their child or their parent would ask the same questions to get information. And so he decided that if all these families are coming in, what a waste to answer each one. Let's get everybody together. Let's get 5 families together, and then they can share their experiences, and they can share their hopes and wishes, and they can share their feelings, and they can help the patients. And we can, so it was a sort of a psychoeducational group, and sometimes with the patients and sometimes not with the patients. And I hope that I've provided you with a little insight into our world.